biochemical assessment is essential, but parathyroid hormone is the most important. Case 2.5-year-old male, mother age 36 years, 155 centimeter, bow-legged, wear partial dentures and hearing aids. Both legs since he stood up at 10 months, walk with waddling gait, tires easily, and use stroller. Height is below the 4th centile and weight below the 9th centile. Sores on gums, dentist prescribe antibiotics. This is the classical X-ray finding of Rickets. Corrected calcium is normal, phosphate is low, alkaline phosphatase high, parathyroid hormone, you can see it's normal, 25 hydroxy it's even high, not there is no deficiency. The 125 hydroxy vitamin D is within normal. Okay, keep it in mind. Only things abnormality here is the phosphate, and which is low, and the parathyroid hormone, it's normal. So most likely it's phosphogenic rickets. So when you have normal to low parathyroid hormone, then we have to next step to measure urine level of phosphate to rule out any phosphate wasting from the kidneys. And of course, if it's low or if it's high, then you have two different differential diagnoses. Before we go to that, there are different sources of phosphate, like as we know from vitamin D. It's either from exogenous factors like diet, seasonal, some endogenous factors, the gender in the male will be having more, and adult, of course, more than kids. Some other facts playing a major role, like parathyroid hormone, vitamin D, and FGF23. And of course, all of you know that phosphate is very essential for the cellular function and for most of the enzymes and skeletal and integrity. So most of the hypophosphatemia in kids are due to decreased either intake, nutritional, or if you are giving, for the example, antacid for them, like aluminum. Celiac disease is one of the important reasons for phosphatemia. Renal leaking, like hypophosphatemic rickets, proximal tubulopathies, modification of the intracellular or extracellular compartment, and other form. There are three main organs to regulate phosphate and calcium: the intestine, bone, and the kidneys. Each has its own receptors, and then at the end we aim to control it. Less than 1%, just to keep in mind, of total body phosphorus is in the blood. Other will be restored in the bone. And so if you have low phosphate in the blood, so it's really low. This is the nomogram for the age. It's different from infants, than toddlers, than adults or adolescents. Usually you need to find it according to the standard deviation to say, sometimes what we are facing in our hospitals, that they are giving you a reference range, which could be normal for the adult, but it's not normal for the infant or toddlers, who they needs more higher level of phosphate for their health, skeletals, and bone growth. So this is how we calculate the phosphate secretion in the urine. We either do urine phosphate, urine and serum phosphate and serum creatinine at the same time and calculate that, or what is called transtubular phosphate secretion using this formula, which you can find it online. The normal range is usually between 6 months to 6 years, 1.2 to 2.6, and adults 0.6 to 1.7. And usually we need to have two samples, and as I said, online calculator is very important. This will tell you if there is a high secretion or wasting of the phosphate from the kidney or not. So if low urine level of phosphate, the differential will be most likely insufficient intake, decrease the gastrointestinal absorption, okay, or extra-renal waste. But if it's high, then most likely it's from the kidneys. And the next will be measuring FGF23, okay, which will give you two differential, whether it's high or low normal. So what is FGF23? It's basically a protein, have two ends, terminus and C terminus. Usually it will act on the kidneys via certain receptors. It will lead to decrease the reabsorption of the phosphate through two receptors, the sodium phosphate transporter 2C and 2A. The 2B actually is found in the intestine, which will lead to decrease in the serum phosphate if you are decreasing the phosphate reabsorption. And at the same time, it will lead to decrease in the 125 hydroxy vitamin D production, the active form, by decreasing the 1-alpha hydroxylation and increase the 24 hydroxylation, which will lead to the decrease in the serum 25 hydroxy vitamin D. So the end result of FGF23 that it will decrease the phosphate, serum phosphate, and decrease the active form of the vitamin D, which eventually will lead to more phosphate depletion. Just a second, please. Okay, because some consultation, sorry. Okay, so going back to the same case, so we remember that we have low phosphate and alkaline phosphatase is high, parathyroid hormone is normal, so, and the 125 hydroxy vitamin D was within normal. We did the to calculate the TMB per GFR, and it's very low, so meaning that the child is losing from the kidneys. FGF23, after that we measure it and we found it's very high. So most likely, if you go back here, if it's high, then it will be hereditary hypophosphatemic rickets, and the most common is X-linked hypophosphatemia. Of course, we have to, in any child with low phosphate, we have to send for a urine to check for amino acid glucosuria, also for urine calcium creatinine to rule out any hypercalciuria. And there is a normal for per age according to different ages. So high FGF23, hereditary, as we said, acquired form. So X-linked hypophosphatemia basically is the most common form of phosphate wasting disorder in 80% of the cases. First time described in 1937. It's X-linked dominant inheritance, so negative family history in close to 50% of the cases, caused by mutation in fixed gene associated with high plasma FGF23 concentration. So very important in the differential that you have very high FGF23. So that FGF23 very high, this will lead to low phosphate, as we saw, and at the same time, low to normal 125 hydroxy vitamin D. It has different features which cross-reacting between starting from infancy up to adulthood. Some are common, some are different, more common in adult than in pediatric. But in general, the general features of rickets, joint problem, hearing problem, gait abnormalities, nerve problem when you are elderly, and hearing loss, of course. So how it happens? You have excess F23, which impair the renal phosphate and vitamin D metabolism due to fixed gene mutation that all act on the osteocyte. So you have high FGF23, which will lead to low phosphate and decreased vitamin D production from the kidneys. This both will lead to increase in the phosphaturia, decrease in the serum 125 hydroxy, and decrease in the serum phosphate, which will lead to the clinical and biochemical features of rickets with high alkaline phosphatase, high transtubular secretion of the phosphate in the urine, normal 25 hydroxy with plus minus family history because it's X-linked, so 50% will not have a feature. And of course, if you send for that gene, you will find the fixed mutation. So how we treat these kids? Early treatment is very important for better outcome. Symptomatic treatment for children with oral phosphate supplement, multiple doses, and of course we have to give the active vitamin D because we know that the active vitamin D will be low. The goal to heal the rickets with normalization of the alkaline phosphatase and normal clinical and radiological signs, control the pain because it's very painful, and try to optimize the growth. Side effects, because we are giving multiple phosphate with active vitamin D to have, of course, hypercalciuria, nephrocalcinosis, and again hyperparathyroidism, because if you have low phosphate and inactive vitamin D low, that will stimulate indirectly the parathyroid hormone to be secreted. There is a new monoclonal antibody that formed, it's prozomab. It's usually given to block the FGF23 action, which is the main state of the pathophysiology of X-linked hypophosphatemic rickets. So case 3, we have 3 years old, white Caucasian girl, flattering growth, height below 3 standard deviation, the weight still below 1.5 standard deviation, bowing of the legs, trips and falls, normal teeth, and normal hearing. Corrected calcium is normal, phosphate is low, alkaline phosphatase is high, with parathyroid hormone is normal. So, okay, hypophosphatemic rickets. 25 hydroxyvitamin D is normal, 125 also normal. TMB per GFR is low, so there is a phosphate wasting. But if you do a urine calcium creatinine in 3 occasions, it's found to be high for the age. Renal ultrasound showed no nephrocalcinosis. So we sent, as we said, we have to complete that by you doing a urine dipstick. pH was 5.5, which is acidic, glucose urea, proteinuria, blood negative. Urine showed generalized amino aciduria, sodium normal, potassium low, acidotic with normal creatinine. So diagnosis, of course, we're thinking about Fanconi syndrome or proximal renal tubular acidosis with this generalized proximal tubulopathy and low potassium with acidosis. So it's a problem with leukocyte cysteine level. This is the problem with the cysteine gene sequences and it's heterozygous mutation. Before I go to this Fanconi syndrome and discuss it in details, usually the diagnosis of this, the most common autosomal recessive cause for Fanconi syndrome, inherited one, is cystinosis, and it's usually due to cysteine gene mutation. So simply, any clinical approach for a child with acidosis and hypophosphatemia and some signs of rickets, you need to differentiate whether it's a normal anion gap versus high anion gap metabolic acidosis. You have a pH of less than 7.35 with bicarb of less than 20. This is confirmed the acidosis. Then you will calculate what's called the anion gap, sodium minus chloride plus bicarb. Normal, it's 10. So if it's a normal anion gap, then you have to think about whether it's GI loss or it's from the kidneys. GI loss, then intestinal bicarbonate loss. If it's not from the GI with no history of diarrhea and others, then it's of course from the kidney. You need to check urine pH. If it's below 5.5, then you're thinking about proximal tubulopathies. You send for glucose urea, amino acid urea, and the phosphate. Then if yes, Fanconi syndrome. If no, then you think about isolated renal tubular acidosis, the proximal type. If the urine pH is above 6.5, you have 2 types. Before that, to differentiate between them, you need to check for serum potassium. If it's low, then it's distal renal tubular acidosis. If it's high, then you think about hyperkalemic renal tubular acidosis with aldosterone deficiency or resistance and renal failure. If the anion gap is high on the other side, not normal, then you think about mud piles, all you know about these differential diagnosis. So Fanconi syndrome basically is dysfunction of the renal proximal tubules resulting in failure of reabsorption of multiple substances with subsequent loss in urine. Polyuria, for example, of course, you will have low molecular weight proteinuria, losing most of the electrolytes and minerals. Usually started in infancy and goes into childhood. Cystinosis is the most common with other inherited disorders. Cystinosis is a treatable cause of Fanconi syndrome. It's autosomal recessive lysosomal storage disease, so it can affect any of the organs. It causes significant morbidity and mortalities with premature death. Incidence is 1 to 100 to 200,000. Commonest cause of inherited generalized proximal tubular dysfunction. And as we said, it's due to lysosomal accumulation of cysteine due to defect in the transport. So normally in a healthy lysosome or cell, you have a normal cysteine level, which can go through the cystinosin transporter. If you have a problem with this defect, then this cysteine will be accumulate and harmful, and it will build up and cause cystinosis. Clinical form of cystinosis, we have the nephropathic cystinosis, infantile form more than 90%, with Fanconi syndrome within 3 to 6 months of life, and this stage renal disease in 10 years. Late onset juvenile form about 5%, with mild tubulopathy, late progression to end-stage renal disease, and ocular form, which is not the nephropathic form, and it's usually overlapping between the juvenile and ocular one. Multi-organ involvement, any system can be involved. The kidneys with Fanconi, this is cystinosis. It can also present in the eye, early, very early in the first 2 years. So you don't need actually genetic test to check for cystinosis. With eye exam and clinical feature of proximal tubulopathy, you can diagnose it. It can cause hypothyroidism because of the cysteine deposit, diabetes, liver cirrhosis, and others. So, normal at birth, failure to thrive and growth retardation is the most common, and you can see there is a retardation in the length and weight, as in our case. Vomiting, constipation because of hypothyroidism, dehydration because of the polyuria, and of course rickets because of hypophosphatemia. And classical feature, they have blue eyes and blonde hair, but it's not always actually. So there are, as we mentioned, different extra-renal manifestation. The most devastating organ is the kidney because it can cause to renal failure and it needs renal replacement therapy, but other organs also are involved at different timeline. So usually Fanconi syndrome and corneal crystals with failure to thrive happen very early during the first year, but others can happen later on. Establishing the diagnosis, usually with a clinical feature, most common in Fanconi syndrome, and we have to start treatment as early as possible. We have to measure the cysteine level within the white blood cell count, and usually, if not to confirm it, we can send for genetic test and of course crystals in the eyes. Treatment, symptomatic, free access to water because they are polydipsic, and of course polyuric. Replacement of the loss, giving potassium, alkaline, phosphate, sodium, and others. Vitamin D, the active form, indomethacin to reduce the polyuria and the urine output. And we have to monitor for other side effects of this medication. Of course, because of failure to thrive and underweight, usually we recommend most of these kids to have a G-tube for supplement of diet, and of course they will be on multiple medications, so it's easy to give it to them. Of course, if they have failure to thrive, we add it to growth hormone. Specific treatment is by cysteamine, which is either cystagon or Procespi, and that help to the cells to get rid out of the cysteine, so to stop the build up of cysteine in the cells. So as I said, cysteamine will try to transport the cysteine out of the cells. We have to start it very early to stop the complications, and usually it's 4 times a day. The other medicine is giving twice daily. Sometimes it causes some GI upset, so we need to give some PPIs. And there is also eye drops for the crystals. It improves the outcomes, as you said that this is a Kaplan-Meier for a patient with cystinosis. We found that using it very early, the treatment will help in reducing the morbidity and mortality and the cause for end-stage renal disease. And this is the statement for the clinical practice recommendation for the diagnosis and management of X-linked hypophosphatemia. Dieter Hafner, you can find it online, and this is my contact if you have any question, and I'm happy to take question, and thank you.
Thank you very much, Dr. Loe, for the excellent presentation. And you made it so, difficult subject so simple with beautiful slides. Really, we are thankful to you.
No,
and now if
welcome.
you can stop sharing your slide, Dr.
I'll stop, yeah.
It was really excellent. We all enjoyed. And now I would like to give an announcement. Before question and answer session, we will have a very short video, and after that question and answer session with Dr. Amir and Dr. Kalpana will start. I would like to give this announcement that the video recording of this webinar will be posted to YouTube channel, Facebook, WhatsApp, Instagram, Telegram, everywhere. So those who have missed or those who want to see again Dr. Loe's presentation, they can see again and again, enjoy. This is really wonderful presentation. And if you watch it 100 times also, you want to see again, it was very nice, excellent. Everybody enjoyed really. I learned many points in that. Now, we will have a very short video. After that, we will come to question and answer. I would like to request all respected viewers to stay tuned. At the end of this webinar, we'll have raffle draw, 3 raffle draw with very valuable prizes. Over to Mr. Tawfiq.
Vitabiotics, an award-winning nutraceutical company. It is the first nutraceutical company to complete 50 successful years. Well Baby Vitamin D3 Drops is a unique vitamin D3 supplement in an olive oil base. No peanut oil, no castor oil like other formulations. Well Baby Vitamin D3 Drops provides 400 international units of vitamin D3 in 0.5 ml and 800 international units per 1 ml. Devoid of any artificial flavors and colors. It contains no artificial sweeteners. Suitable for vegetarians. Suitable from birth onwards. It contains easy-to-use measuring syringe. Well Baby Vitamin D3 Drops is covered in all insurances including PCP, RN3 and Abu Dhabi Basic Plan. Well Baby Multivitamin Drops is the ideal supplement formula for babies from 1 to 12 months. It contributes to normal cognitive development of babies. Supports normal growth and development of bones in babies. Helps to boost immunity in babies. It is an appetite enhancer. Supports overall health and wellness in babies. Contains no artificial colors or sweeteners. Dose. For babies from 1 to 12 months, give 0.5 ml twice daily. Vitabiotics is proud to present the comprehensive multivitamin formula for babies aged 6 months to 4 years, Well Baby Multivitamin Liquid. It contributes to normal cognitive development of children. Supports normal growth and development of bones in children. Helps to boost immunity in children. Provides required nutrients for picky eaters. Supports overall health and wellness in children. Dose. For 6 months to 4 years, give 5 ml daily, 1 teaspoonful. Well Kid Omega-3 Chewable Capsules. Vitamin D helps in increasing the immunity. Omega-3 improves concentration and attention span. It builds eye health by improving tear stability, optimizes the brain functions, boosts the synthesis of dopamine that helps in ADHD symptoms, acts as an anti-inflammatory source. The dose is 2 capsules daily for kids aged between 4 to 12.
Thank you very much. Now I would like to request Dr. Amir and Dr. Kalpana to start the question and answer session. And I would like to request all the viewers to write their question in the question and answer box so that all questions will be discussed. Dr. Amir, please. Dr. Amir, your mic is mute, unmuted. Mic is on mute.
Okay,
Yes.
thank you, Dr. Loy, about this very informative presentation. I want to ask, there is 2 questions from Dr. Manoj Chandran. The first one is, up to what age the children should be supplemented with daily maintenance dose of vitamin D? Dr. Loy?
I think his
Yes,
Yeah.
yes.
Okay.
Dr. Loy, you
Yes,
heard the question?
Yeah, I heard the question. So
Yeah.
basically, there are different guidelines, European and American guidelines, but the consensus about vitamin D supplementation for the first year is 400 international units, especially for breastfed infants. From 1 year to 2 years, usually we increase it to 600 international units. But for how long, here is the controversial. Sometimes we can say up to 5 years, sometimes even up to 2 years, and it will be enough. I can't tell, it will be different from one child to another, from one society to another. For example, if for high-risk children, dark skin color, from Africa, if they have other not enough sun exposure or malnutrition, then I would recommend to use it longer than the usual, like more than 2 years. But if the child is healthy, growing fine, usually 1 year and up to 2 years will be enough. It depends, it's different from one child to another.
Okay. Do you think that as long as the child not exposed to sun enough, have to be take vitamin D?
I mean, it will not harm. I only see hypervitaminosis in premature kids when we are giving it. But in general, most of the children will have like vitamin D deficiency. So a maintenance dose usually will not cause harm. And even, you know, when you are talking about sun exposure, usually it should be below 10 o'clock or after 4, which sometimes difficult timing and for these kids.
Okay. The other question, the second question from Dr. Manoj also, I think you answered in your presentation. Is there any clinical studies or RCT which compare the efficacy of vitamin D3 and vitamin D2 in maintenance or in treatment vitamin D deficiency and active rickets?
Yeah, there are many. Actually, but
vitamin D3 is more.
Yes. Yeah.
Okay.
I mentioned that.
The last question, how can we explain a case with a very low vitamin D titer, less than 10 nanogram, but with normal phosphate, normal alkaline phosphatase, and no signs of rickets?
It's an evolving stage.
Yeah.
Give it some time, and then the child will have
it.
Maybe they have enough reservoir, and then after that
we'll start.
Yeah.
Okay, Dr. Kalpana, if you have any question.
Yeah, sure. Thank you, first of all, Dr. Loy, for this interesting lecture. Before I proceed further, I just want to ask you whether your camera is covered because your picture is coming very hazy. So
I'm busy.
don't want to trouble you too much today because, as you mentioned, you're not feeling well. There's a question from one of the attendees, Dr. Jawad. He is asking, what is the duration of treatment of nutritional rickets? If you choose to start vitamin D3, what would be the duration you'll be treating a case of nutritional rickets?
For nutritional rickets, you know, as we said, if it's insufficiency, whether it's mild, it's different from moderate, from deficiency. So the duration will be between 2 months to 3 months, and the doses is different according to the level of deficiency, which is, I did not go through that because most of you, like, I mean, it's available and a lot of resources of that. But ideally, it depends on the level of the vitamin D. This is number one. It's between 2 to 3 months, and the dose again depends on the severity of the deficiency.
Okay. There's another question from Dr. Omar, who wants to know what would be the steps to take while treating X-linked hypophosphatemic rickets to reduce secondary hyperparathyroidism.
So as I said, ideally, we should treat symptomatically by giving phosphate to maintain at least low normal, because it's difficult to normalize it. Try to give the active vitamin D, whether it's calcitriol or alpha calcidol, with the minimal effective dose, but trying to avoid nephrocalcinosis. And most of the time, it's difficult. It's a compliance issue. It's not, you cannot just maintain 4 times a day to give the child the phosphate or the vitamin D, because, you know, it's like a pouring tank. If it's you're giving the phosphate, the child will lose it. So ideally, we should, if there is any manifestation or complications started very early, then we have to think about the other treatment, the prozomab. But I would recommend if the doctor has this, like such patient, to refer, and then we can take it from there, actually.
Okay, there is a question from Dr. Nasma Karawi. Any recommendation for blood sampling and collection and transportation to lab for parathyroid hormone test? How possible to have false results?
I never had any problem, actually. I don't know about the transportation and these logistics, but I never had a problem with the parathyroid hormone reporting. Like, I mean, if you have reliable and trusted lab, unlikely you will have any problem with that.
Okay, there is from Nilson Jawad. What are the indications to start vitamin D3 supplements since birth? I think you answered.
We mentioned that, yeah.
Okay. From Dr. Mona Youssef, what the ideal time to exposure to sun, summer or winter? Also, I think you answered about that. You mentioned that.
Yeah.
You mentioned that you see hypercalcinosis or hypervitaminosis, sorry, in prematures. But I would like you to say a word on rickets of prematurity. You know, do prematures require, we need to take care of the calcium?
Yeah, of course. I mean, the standard of care that in all in ICU units that you will supplement the children with premature babies, sorry, with multivitamins and vitamin D, phosphate for sometimes quite time. But this is what I noticed recently. We are getting a lot of referral from our colleague in ICU that these kids start to form nephrocalcinosis.
Yes.
Very interestingly, when you are comparing even the twins from the same family, they have the same dose, but one will develop nephrocalcinosis, the other will not. So we're checking the level of vitamin D as like a routine, and you will find that vitamin D, for example, is more than 100, 110. So definitely it's hypervitaminosis. You check urine calcium creatinine, it's high for the age. So we ideally stop the vitamin D for them and monitor serial vitamin D and calcium and phosphate. And we give time for the ultrasound changes to show, because it takes time, actually 6 months or more. But it's very important, I would just, it's a message for our neonatologists to keep an eye on it. It's different from one baby to another. Some babies will have low threshold to develop nephrocalcinosis, the other will not. So it's not like a rule of thumb, just blindly to give all the babies vitamins and phosphate.
Yeah, and especially prematures, the nephrocalcinosis can be multifactorial in prematures. So we would be adding one more factor for that. There's the other thing, I think from a general pediatrician's point of view, what we would like to know is, should the full panel be asked in a case of suspected rickets? You know, you have classical features. Would you be doing calcium, phosphorus, alkaline phosphatase, 25-hydroxy, 125-hydroxy, and PTH? Would you recommend that?
No, I mean, I explained it in my talk. First of all, if the patient is a cash patient, different than insurance. Regardless of that, we need to start step-wise approach. I mean, calcium phosphate, alkaline phosphatase with simple X-ray just to confirm that this is rickets. Then parathyroid hormone. It will tell you which way to go. I mean, from the clinical history, if it's simple, straightforward nutritional rickets, then you will just do the 25-hydroxy vitamin D. If low phosphate, then for sure, you have to go for the inactive, the active form to differentiate the different forms. But if it's calcipenic rickets, most of the time it will be like a nutritional or like dietary deficiency, and then you can just give a trial of giving calcium and vitamin D. No response or still there signs, as I mentioned, then you think about the more complicated cases.
Okay, other question, Dr. Zubaira. If we are giving multivitamins, do we need to give vitamin D3 drops separately to child? I think it depending on how much vitamin D in the multivitamin.
Exactly. Most of the multivitamins will have, some of them, 200 international units. The others have 400. So as you're right, it depends on the preparation itself.
Okay, can be the sun exposure in UAE an effective preventive measure? I mean, there is a dust.
I'm not sure. I don't think so.
Okay. When should we check blood level of vitamin D, and how to follow up if low and under treatment?
So as I said, if severe deficiency, you will give at least for 3 months. If you are giving, for example, the child once a week of 50,000 units for 12 weeks, then you repeat it after 3 months. You don't have to repeat it after a month. But the child, you give the treat. So you have to complete the course of a treatment, then you have to repeat. So it depends on how long you will treat, then you will do the blood test.
Dr. Pankaj wants to know whether the buccal spray of vitamin D that is available will be as effective as a newer
I
form.
heard about it. I never use it, honestly speaking. But I hear the good things about, but I never use it. Yeah.
Right. And Dr. Krishnamurthy was asking whether, would you recommend daily dosing or weekly dosing to enhance compliance?
Weekly, I prefer usually weekly.
Dr. Vatin asked about what are the symptoms of hypervitaminosis D?
So the early symptoms, the early symptoms will be nephrocalcinosis. If not nephrocalcinosis, at least hypercalciuria. So this is the most common. Sometimes you will have high calcium, high normal calcium very early, but not much actually.
Did you see hypervitaminosis D with the normal daily allowance of vitamin D taking? No.
Dr. Manjari Rao has a question. Is it true that retinol is important for activation of vitamin D receptors?
Vitamin A, you mean retinol?
Mm-hmm.
I don't know. No, I don't think so. I have no idea about it. Yeah.
Okay.
We'll take one more or two questions.
Dr. Bankaj asked about there is
till morning they will ask questions. I said,
I know, yeah.
They have found you. They have a lot of questions.
I left my contact. Anyone can email me or talk to me. I'm happy to help. But like if we keep it open, it will stay till morning.
Yeah. So we can stop now?
No,
You can take one
let's
more.
do one or two more questions.
Dr. Bankaj asked about so many newer vitamin D products in market given as
I think we
buccal
asked him that.
spray, and
We asked
that's
him
how
that.
to ask it. And a recommendation to check the vitamin D level for children receiving or not maintenance supplement. Also, I think it's answered.
We answered that. Yeah.
Now, regarding cystinosis, is there any increased incidence in UAE is what I wanted to ask.
Yes. Yeah, this is because it's autosomal recessive disease, and usually it's very common among consequence marriage. Yeah.
Absolutely. So in this case, is there a prenatal diagnosis available?
Yeah, I mean, it's part of the fetal medicine, like chronic villus sampling. Yeah.
So it can
because
be
it's
done.
known, yeah, cystinosis. Yeah, yeah.
Right.
Cysteamine.
And out of the difficult to treat rickets, which would be the most difficult in your opinion? Which type?
It depends. It's different from, like, for example, the X-linked hypophosphatemic rickets. If you are the child is not compliant, and you are not able to give them the new medicine because of the expenses, then they will feel having complications and side effects. On the other hand, for example, the Fanconi syndrome, they will have multi-organ involvement. If it's cystinosis and the treatment is very expensive, they will end with end-stage renal disease. So it depends on the underlying. I don't think the vitamin D nutritional or the vitamin D dependent rickets is as bad as other form of like hypophosphatemic rickets.
Right. Finally, the monoclonal antibody that you spoke about, how often is it used? What's the duration?
Every 2 weeks for life.
And for how long?
For life.
Yes.
This is the last one. Is it true that retinol is important for activation of vitamin D receptor?
I don't know.
Dr. Zuhair also, Mahmendar asking for extreme premature baby, we have to give alkaline phosphate. How long with multivitamin?
Alkaline phosphate.
Alkaline phosphatase, you mean phosphate?
He mentioned alkaline phosphate. I don't know why.
Maybe phosphate. No.
Yeah, maybe phosphate.
Yeah, phosphate. They are giving sometimes phosphate, but this is what I'm saying. I mean, with high level of absorption, sometimes you will have, because even you have tubular immaturity. So the phosphate leaking, calcium leaking, even without giving vitamin D, will be very high. So they have a higher incidence to have nephrocalcinosis.
We would like to thank Dr. Loe. I would like to give this news to our viewers that all questions will be sent to either WhatsApp or email, and we'll request Dr. Loe to answer those if left. Now, before announcing the raffle draw winners, I would like to give an announcement. Our next DPC webinar will be on 6th Friday evening, and we will have our annual virtual conference on 28th November. And now I would like to request Mr. Tawfiq to announce the raffle draw winners. And this, I would like to say that the video recording of this webinar in few days' time will be posted to all groups, so you can see those who have missed. They can watch it in the form of video. Yes, please, Mr. Tawfiq.
Okay, I would like to leave because really I'm tired. So I thank you. And if I win
thank you very much, doctor.
If I win the raffle, you can send it to me. Okay. Okay. Have a good night, everyone. Thanks, and pleasure to meet you.
Good night. Thank you very much.
Welcome. Bye-bye.
Yeah. So let me announce the raffle draw winners. Okay, so the first winner is Lyudmila Borisenko.
No, but check it is there or no. They should be there. They should be present.
Lyudmila Borisenko, the first winner.
Oh,
okay,
no,
I'll go to
winning.
Second name.
Jimmy John.
Jimmy
Oh, Jimmy John is our Jimmy John is our pediatrician from the pediatric club, I think.
Yeah, I think I'm not sure. Jimmy John, it's written. And the third one, and the final, Ijaz Wasim. Ijaz Wasim.
Congratulations. They are there.
Ijaz
Please
Wasim.
indicate.
Yeah. So with this, we come to the conclusion. So before closing, I just like to give a vote of thanks. So I'd like to thank all the delegates who have come online, who took time and attend our webinar. As usual, it's like a continuous webinar series going on since last 3 months. So I'd like to thank Dr. Lloyd for this wonderful talk he has presented tonight. And hearty thanks to our panelists, Dr. Bhandari, Dr. Amir, and Dr. Kalpana for taking up the questions and answers so beautifully. And the program is accredited with 2 CME points. So you will receive a link within a couple of days for the post-webinar questionnaire. So please fill it so that you can claim your certificate. So until then,
Just one.
So Dr. Sundar will close the things, inshallah. Thank you very much.
I would like to really thank our viewers. Today we had 2,758 registrations from all over the world. It was really amazing. I would like to thank all of you. I would like to thank distinguished panelists also, Dr. Bhandari, Dr. Amir, Dr. Kalpana. We would like to thank Tawfiq for sponsoring this webinar, Fadi. Once again, all the viewers, please join us on 6th and our annual virtual conference on 28th. Thank you very much and good night.
Thank you.
Good night.
Good night.